Hello, we'll be discussing about the sonoanatomy of upper limb muscles for botulinum toxin injection. I am Dr. Naufal Ali. I am specialized in physical medicine rehabilitation. I'm a physiatrist. So I don't have any conflict of interest and my our learning objective will be to uh, see the upper limb muscles with regards to botulinum toxin injection, sonoanatomy. So some of the common muscles in upper limb which are affected by spasticity including pectoralis major will be discussed. Pectoralis major has a clavicular and sternocostal heads, so it's better to inject at 2 points for better results. So this is a patient lying towards a cephalocaudal, and this is the upper limb. So this is the area where you can see pectoralis major. You can keep the probe over there, and here skin, then subcutaneous tissue, then muscle can be seen here, pectoralis major and then minor. So once you see that, you can take the needle towards that muscle and inject there. So here the muscle is very much visible. Coming to elbow flexors, biceps brachialis and brachioradialis. Both biceps and the brachialis pass through the arm. Brachialis origin will be a little bit more distal when compared to biceps. So to see brachialis, you'll have to go a bit more distal. And the insertion will be to the radial tuberosity for biceps and ulnar tuberosity for brachialis. Brachioradialis will be a little bit more distal. We'll discuss it later. And this is a cross section at the level of the arm where you can see biceps superficially and brachialis deep to that. So when you see in the ultrasound, first you will see biceps and then brachialis. And brachialis is more exposed on the lateral aspect. So in anatomically guided injection, usually brachialis is injected from the lateral aspect to reach the muscle fast or easily. This is an image showing the muscle coming from the coracoid process. Here you can see the coracoid process and medial epicondyle, and approximately at 65% in the line between these 2 points, you can keep the probe in transverse position, and then you can see biceps superficially and brachialis medially, and this is humerus. So this will be the vision. And then if you come a little bit more distal, you can see brachialis muscle belly is more prominent here, the distal one. So this is a video showing the muscle belly a little bit proximally. Biceps is bigger, brachialis is smaller, and when you come down, biceps is becoming smaller, small, and the brachialis is becoming bigger. And after, when you come still more distally, brachialis is also becoming smaller, going for insertion. This is hyaline cartilage at the level of the elbow. So this is brachialis, another video showing brachialis muscle. And the muscles at the elbow, to see the muscles, first you have to try to get this hyaline cartilage. This is a very beautiful image at the level of the elbow where you can see the hyaline cartilage, and the muscle just above that will be brachialis, and radial you can have brachioradialis, and medially you will have pronator teres. So this will be a classical image you get when you keep the probe at the level of the elbow. And then brachialis at the middle, brachioradialis laterally, and pronator teres medially. So this is a video beginning from the lateral aspect. So here you can see brachioradialis, here brachialis, and here pronator teres. And when the probe is brought down, this pronator teres moves laterally slowly. It moves laterally and tries to get inserted there. And then you can see flexor carpi radialis medial to that. And this is palmaris longus. So here again, you can inject all these three muscles. So this is pronator teres, and when it comes down laterally, then you can see FCR and palmaris longus. FCR is flexor carpi radialis. So pronator teres has two heads, humeral head and ulnar head, and medial nerve passes in between. And this is an ultrasound image showing the median nerve. And this is an image showing palmaris longus and FCR. So this is flexor carpi radialis, and medial to that you will have palmaris longus. Here you can see FCR, and in between tendon is becoming evident here a little bit more distally. So this is a video showing again pronator teres, FCR, and palmaris longus. And when you go more medially, you can see ulna, and just above the ulna, it's not flexor carpi ulnaris but flexor digitorum profundus, and above that superficially you can see flexor carpi ulnaris. This is an area where some people get confused. So flexor carpi ulnaris is more superficial. And if you want to, you can actually try to move the wrist and see if the muscle belly actually moves. So this is FCU, and then deep to that is FDP. So coming to distal forearm, you can see two layers of muscle. The superficial muscle is flexor digitorum superficialis. That's why this name. And then flexor digitorum profundus is the deeper muscle, and flexor pollicis longus is there on the lateral aspect. So there are three deep muscles in the forearm: flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. Still more distally, which we'll be discussing. So here you can see FDS in the superficial aspect and FDP in the deeper aspect. This is another image showing how flexor digitorum profundus injections are done in anatomically guided techniques. Usually, the patient is asked to flex the elbow, and from the ulnar aspect, the injection is being done to FDP. This is one of the other ways, but usually in ultrasound, we can do it the normal way, like you can go from the anterior aspect and directly go to FDP also. So these are the three deep muscles: flexor pollicis longus, flexor digitorum profundus, and pronator quadratus, which is seen between radius and ulna distally. So to see flexor pollicis longus, keep somewhere around the mid of the forearm, a little bit more distally maybe, and here you can see the radius, and ask the patient to move the thumb or else try to move it passively. You can see the contraction of the flexor pollicis longus. Pronator quadratus will be seen more distally, where it will be seen as a boat-shaped muscle in between radius and ulna. Coming to the hand, if the patient is having thumb in palm deformity, maybe you'll have to inject flexor pollicis brevis also. And slightly lateral to that, there is abductor pollicis brevis. It's important to understand which is the muscle exactly and then inject accordingly. Opponent's pollicis can also be seen. So when you keep the probe over the hand, just parallel to the thumb, a little bit laterally, first the muscle you will be seeing is APB, abductor pollicis brevis, but the flexor pollicis longus tendon might not be uniformly visible. Some fibers will be there, some fibers will not be there. So what you can do is just move the probe a bit more medially. If you move it a bit more medially, flexor pollicis longus will become clearly visible. And the muscle above that will be flexor pollicis brevis, and below that will be adductor pollicis. Both can be injected in a single prick for thumb in palm deformity. And then coming to lumbricals, lumbricals can be injected if the patient is having intrinsic plus deformity because of spasticity, spastic lumbricals. And lumbricals are usually seen in between long flexors. So first identify the bones, interossea between them, and then identify the long flexors and lumbricals are between them. So in this image, if you keep over the palmar crease transverse position, you can see the bones, the tendons, and then the lumbricals in between. Thank you.